Welcome to the Academy of Neurologic Physical Therapy Neuro Rehab Educators discussion. Tonight it will be led by Sue Perry, the Director of Education for the Academy.
Well, welcome to everyone. It's been kind of fun seeing everyone come into the room. Some old people like me, some new faces and new names who I am not familiar with. So welcome to everyone. My name's Sue Perry. I've been the Director of Education for the Academy for a couple years now. It's been a whirlwind. I also teach full-time in the physical therapy program at Chatham University in Pittsburgh. I've been there for 25 years, so have the same interest in neurorehabilitation curricula that you all do. So I wanted to just go over this slide to give you a sense of what I have cooked up for the next hour or so of your lives. I call this meeting what, why, and whether. So what are we teaching with regard to traditional versus contemporary approaches, what we're teaching, and whether or not we should continue to teach it. So we'll be doing some polls. The first poll will be who, so I'd like to know who is on the call. So that will be coming up momentarily, so you can just sort of say whether you're a PT, PTA educator or a non-academic educator and how many years of experience you have. And then we'll have another poll about how many hours you have within your curriculum if you are teaching within an academic curriculum of traditional versus contemporary approaches. And then, so that's the what, and then the why is I want to just find out maybe what your drivers are for your curricular decisions at your institutions. And then we'll have all that information to go on together because we'll see the poll results, and then we can kind of start having a little bit more of a discussion. So really, the purpose beyond that is that ANPT wants to listen. You know, it was apparent on the listserv that people have varying opinions and perspectives, which is grand. And they want to share them. And so this may be the first of many discussions that we have. So ANPT wants to be able to provide a forum and to understand the what, why, and whether a little bit more. I will say I know that some people are very passionate about their perspectives, and just some ground rules for this. This is a very safe space, not going to surprise any of you in academia. We always talk about how it's a safe space for discussion. And so I'm going to try to promote that kind of culture on the call. So I'm going to ask Andrea to put up the first poll, if you would, Andrea. And that's going to help us figure out the who. All right, so it looks like the poll has built, and so so I think that you can see that most people, although are in that 5 to 15 year range, and there's some newbies and some old bees, me being one of them. And you know, I chose that 15-year mark because that's how many years ago 3-step was. And so I'm going to talk about that in a little bit. So recording, and we may go back and look at this a little bit more, some of these results. So I'm going to stop sharing that. And Andrea, if you could put up my second slide instead of the first slide. So I was talking with some colleagues today, and my colleague shared that the year that I personally became NDT certified, she was 1 year old. And so I thought it might be worthwhile, since again, there's a bell-shaped curve of people's experience, to just talk briefly and provide some historical context from someone, maybe a PT who lived through it as a clinician and an educator, about kind of where we've been and where we might be now. And maybe that forms a little bit of the basis for some of the varying perspectives. I'm just going to like talk for a paragraph, don't worry. But you know, I was NDT certified in 1984, and you know, there were the 4 big approaches back then, and they were very much based on the reflex hierarchical model of motor control. That was the best science at the time. And then the approaches advanced so that the big thing was integrating those 4 approaches, as opposed to just being a PNFer or an NDTer. But then along came two-step in 1990, a seminal conference, and the idea of a different framework for motor control, a systems framework, became maybe a little bit more prevalent. And approaches that were seated in the systems model of motor control and more about motor learning really came out of two-step. And then by three-step, which was in 2005, 15 years ago, the emphasis was very much on neuroplasticity. And so I think some of the concepts around motor learning and motor control then were kind of turned into what can we do to drive neuroplasticity. You know, the idea of some of the more traditional approaches under the reflex hierarchical model of motor control was, how do we get into the nervous system? We get into the nervous system, we influence the nervous system with our hands and our sensory and other kinds of feedback. And boy, by the time we get to 2005, we find out we really can get in there and influence the nervous system and make changes, but maybe with some different approaches. And so that sort of maybe brings us to, in entry-level curricula, there's a wide variety of tools that we can provide for our students. Some of them are contemporary and some of them are more traditional. And so that kind of brings us to the what. And so I'm going to ask you to do another poll that talks about the curricular hours within your curriculum. So, I mean, I had in my head that I would summarize these, but it's probably not important because you can see that. And again, we may share some of this data in another way, but yeah, I included PNF as sort of a therapeutic exercise kind of thing. So I guess another poll question might be, how much time do you spend on task-specific practice and motor learning? But I didn't include that because that's really not what we're talking about today. But it does seem like, as I'm looking through this, and you would probably agree with me, that there are still maybe a chunk of people that definitely, I mean, this would definitely have to be some lab time, right? Over 50% of people, maybe less on Brunstrom, but for sure on NDT and PNF, for sure there is some significant amounts of time devoted to that. And even more so maybe if we add in the stuff that is being taught that is not being named. So I am going to, so again, I mean, some of us are just talking about these things with regard to a historical perspective, and others are spending more time in lab, as I said. And again, thinking back to that NeuroListserv conversation, you know, this can create some dissonance for our students when they go into clinical practice. If they learn one thing in the classroom and something different in the clinic, or if they get to their clinical experiences and their CI looks at them like they have 3 heads, because how could you never have heard of Brunstrom or kind of thing. And so So that dissonance, of course, exists in other parts of our practice, right? You know, maybe we teach them to use a gait belt all the time in lab, and they go into clinical practice and there's no gait belt, right? Or for sure in the musculoskeletal practice, I know there is some dissonance. And I haven't used the E word, I haven't used the evidence word about whether there's evidence for or against any of these necessarily. There was certainly some talk about that on the listserv as well. But that might come up when we get to the why, which is our next poll. Wow, so that's interesting. And you know, some of this data might inform our conversation as we go along this evening. You know, that whole, so, you know, I think probably the conference content and the published articles are kind of around evidence. I have a sense that textbook outline maybe is something that supports newer than more experienced faculty, but certainly is important. And again, that whole, well, we've already done it, always done it this way with the institutional precedent, again, might influence, well, maybe not just newer faculty. You know, we need to think about the licensure exam outline and whether there's something that we might be able to do about that. Perhaps not, but anyway, still quite a variety. I know, Pat Sparto, you're wanting to come up with some kind of graph to show this in a different way. I guess it is kind of a bar graph if you look at it sideways. So, okay. So now what we would like to do is hear from you. But anyway, my first question then, to sort of tag on to the drivers of curricular decisions, like those were just my ideas, but I'm interested to know now from more of you about if there is more depth to go into about what your rationale is for either including or excluding content. You know, maybe we only have so much space and so much time. I mean, maybe that's a piece, but I want to stop talking and do a little bit more listening now that we're 20 minutes in. So my question is, what is your rationale for curricular inclusion or exclusion? And that's this question right here. So we're still talking a little bit about the why. If anyone has anything they would like to share.
Hi. Yeah, I would just say that I'm currently looking at some of our neuro rehab curriculum, and in particular because I've had clinicians in the community who have our students tell me that they are not able to use PNF and the PNF techniques that students learn in class and come to clinic wanting to use effectively in their clinical setting because of time constraints and whatnot. So we had in the past spent quite a bit of time on that in our curriculum, and I'm looking together with some of my adjuncts and other faculty at how we can use some of that most effectively and efficiently, but maybe pare it down a bit because the students just aren't actually being asked to use it in clinic so much, or they don't have time to use it when they want to.
So that's interesting. That's a little bit inside out. There are clinicians who say what you learn in school isn't necessarily relevant because of time constraints versus, oh, you didn't teach what we're doing here. So that's an important consideration. Niam, I'm sorry that I don't know how to pronounce your name. Niam Tooney, I think had a hand raised. You want to unmute?
It's NeuroEducators2020. And I agree that I have had actually a completely different experience with the students when they go out to clinic. If they go to a clinic where the clinicians don't use PNF particularly, they are frequently asking the students to show them the techniques they are using. So I thought that's kind of a flip side to that. But when it came down to deciding how much time to spend on what, I looked, you know, I'm an older therapist. I have received training in all the approaches. I have used all the approaches in clinic for decades. Every time a new approach came out, I made sure I learned it and was able to apply it. And I feel like the more options that students have when they get out to practice, the better for the patient. There's actually evidence to show that they all tap into neuroplasticity, the principles of neuroplasticity. They may tap into the different principles to a different degree, but essentially they all tap into the principles of neuroplasticity, which is why I think there is such a conversation about what works and what doesn't work. I think that the traditional approaches have very poor evidence because very little quality evidence has ever been done on them. And the more contemporary approaches are much better researched. And I think that is a fault of the traditional approaches, that they have not made the effort to really develop good quality evidence that we can use. I teach the contemporary. If I looked at contemporary, I probably spend as much time on contemporary as I do on the traditional combined. Still think there is a place for the traditional approaches in an entry-level program. And I think, you know, we have to decide how much time that might be. And I think a lot depends on the experience of the instructor and the skill of the instructor in terms of how much time and effort they put into them. But the feedback I've had from clinics and students is that they like having the traditional approaches in addition to the contemporary approaches. And in general, most of them have been allowed the leeway to use them and to do case reports on them, or, you know, whatever they need. So I think there is room for it all. I think the more options we have to offer our patients, the better. I think that there is room for multiple approaches in patient care. And I think the one thing that's really missing, particularly in PNF, is any kind of quality evidence. And I'm reluctant to use bad quality evidence to dismiss an approach. The contemporary ones are just much better researched.
Sure. Thank you. Patty Cluting had her waving her hand.
Yeah, I started to put my hand down because so many of the points that were just made were in alignment with what I was going to say. But I'd just like to add, I think it's really important to have strong clinical partnerships, and we're not teaching our didactic courses in a vacuum. There should be a dialogue that is not just, you know, an individual student does well or doesn't well, but kind of a engagement of the clinicians on a regular basis into what we put into our curriculum in order to allow our students to be successful. And to me, that goes beyond technique, but more what's the framework, what's the clinical reasoning skills, what's the adaptability, and you know, how can we help our students be prepared so that they can be in the clinic and be successful. So you know, again, I don't want to repeat what's already been said, but I just thought that was a piece of it that I haven't heard, is that you know, the dialogue and kind of really thinking about the outcomes and thinking about how does didactic education and clinical education partner for the benefit of the students and our future patients.
Thanks. Rachel Tappan, what would you like to add?
I guess as I hear you two talk, I'm struck by the idea that there's so much time for teaching. I mean, I guess it's not been my experience that we have time to teach all of those. My experience is that we don't have nearly enough time to teach everything we'd like to. And I think in that context, it feels particularly important to me to really think about what has the most support from an evidence standpoint. And I think that means really not spending time on the traditional approaches and focusing more on the contemporary approaches. And I hope that as part of that, though, then, you know, at least the team I'm on, I think our goal is to provide the students with a framework as well, though, so that anything, because it really isn't about the technique, right? It's really about being able to evaluate the evidence, because I certainly hope, you know, my practice looks very different now than it did, you know, 10 years, 20 years ago. I went through NDT training as well. But then as more evidence became available, my practice changed. And I really hope that we're providing then our students with a framework to be able to learn new things. And so they'll see new things in the clinic that maybe we didn't teach them exactly in class. But then if they've got the framework for how to think about how that fits into their ideas of movement and evidence and all of that, then they can decide what place that has in their practice. I also hope that the things we teach them now, they'll have some completely new set of skills to be using, 10 years from now. So we really, in our program, really don't spend time on traditional techniques such as NDT and PNF. And I, at least from my standpoint, I think that's why.
Rachel, can I ask you a follow-up question? When you said provide the students with a framework, you're talking, I think, about a framework of when a student sees a new, anything new that they haven't learned, they have the ability to evaluate it on its merits, right? That's the framework that you're talking about, not like a motor control framework or anything, right?
Well, but the motor control framework plays into that, right? So I'm at Northwestern, and so we use the motor control framework really throughout the curriculum. But I think there's also, a framework of evidence-based practice that fits within that, right? So as I think about, as I learn about new interventions or ways of doing things, I'm fitting that into the motor control framework just because that's how I think about things. But then I'm using what I know about evidence to see how it fits there. How does it make an impact on their movement? So I do think it all goes together. But that's where for me at least, those frameworks, that's how I get an idea of kind of where to plug things into as new things come along. But in the end, it all has to be based in evidence, to the extent that we have evidence.
And as you say, the evidence-based practice, of course, is more than just the published evidence. There's those three legs to the stool of evidence-based practice. David Lehman has a hand up.
Good evening, everyone. I am
Hello.
so excited to be a part of this. I've been calling for this since 3-Step probably, because 3-Step certainly shook my world in the way that I believed neuro-PT should be taught when I came out as a new instructor. I think, we hear a lot about basing our treatments around movement, strategy, and function. And if any of these continuing ed, profit-making type approaches are appropriate, it seems like the only way we can get evidence on them is to follow their protocol. But what I find is that we can use manual guided techniques or movement patterns instead of saying it's NDT or PNF, and maybe get some results that affect movement and function. But when it comes to evidence on these particular product named approaches, there's a disconnect there because we have to follow their protocol, just like LSVT. Instead of just saying chewing works, if you use LSVT, you have to follow their protocol to say it works. So there's a little discrepancy there, I think.
Thank you. Nancy Devine?
Hi. So I guess the only thing I would add to what has already been said is I have included a brief section on the traditional approaches and a description of that reflex hierarchical model of motor control as a way for students to recognize where we came from in PT practice and to be able to recognize what they could see and then spend the majority of time on the contemporary while trying to encourage them that transition from that reflex hierarchical to the contemporary occurred because of a change of understanding of the nervous system, and that the task-oriented approach or task-specific training isn't just about being functional. It is a way to assist motor control that emerges through that interaction of the person, the task, and the environment. It in and of itself becomes the manner in which someone can attempt to develop a different strategy that just voluntarily they can't emerge without thinking of that task, as a way to then say during their, what I call their practice lifetimes, the time that they are practicing as a PT, new information will become available and they need to be ready to adapt and adjust and recognize now what changes need to be made. So including those traditional approaches are a way to show that change does and should occur, and often how slowly it takes to be incorporated. So I just wanted to add that perspective.
Thank you. So Vicki Johnson, I think, has her hand raised. You would care to?
Hey, can y'all hear me?
Yes.
Hi. So I'm only one of the 13%. I have done academic education as well, but the majority of my life has been non-academic. Just to tell you who I am, I have been teaching PNF for 43 years, and I trained directly with Maggie Knott at the birthplace of PNF, which was Kaiser Vallejo in California. And my husband is part of my team. He actually taught with Maggie for 7 years. And I just wanted to be part of this because, first of all, I think it's so important. And first of all, I want to acknowledge and applaud this forum, because if we don't have discussion between the people in the clinic and the people in academia, the only people that suffer are the students, but ultimately it's the patients. So first of all, thank you for having this forum. And my purpose of being here is to hopefully shed some light from the other side of the ballpark, and to let you know that when I've listened to some of the positives and concerns, really heard negatives, just concerns about including the historical approaches, I realized that part of the problem is the lack of education of the evolution of some of these historical approaches. I can only really truly speak to PNF because that is what I have taught and been involved in for 43 years. But there are no protocols in PNF. There are principles that have proven to be timeless, principles that tell a therapist when they touch a patient, it matters where and how you touch a patient. Principles that say it matters how you position your patient on the plinth before you do anything to them, or principles that say it matters how you position your patient in a chair before you attempt to teach them the functional task of sit to stand. You see, these are all the principles that are embodied in PNF. And I completely agree that there's very little time within an academic setting. I mean, we spend almost 30 hours just trying to teach the very basics of PNF to those in a post-professional continuing education class. And even then it takes months and months of practice to really feel like you understand it. So I agree with you. I think there's a limitation on time. I think what I would like to see throughout this forum, and I'm going to just be part of it and chime in every now and then, is how to come to an understanding of what could be taught that could encourage the students to know that there's more, that there's never an opportunity within an academic setting to teach everything. But if we don't train our students to know that they must continuously be pushing themselves to be better and know more, our profession as a whole will not maintain its edge on patient care. And so I just want to join the conversation in trying to help the academic people know that from the clinical setting, what would we like to see the students have when they walk into our clinics? Not necessarily the manual skills, definitely not the patterns of D1, D2, but how can we teach them the principles of PNF that are in fact timeless in their application?
Well, I'm probably one of the older PTs on here who recognized your name right away. So thank you for being here. Can you just say again, though, from your, I know it's just your opinion, but I so appreciate when you say it's not protocols, it's principles, and the principles, the examples that you gave, like when I hear those, I think about biomechanics, some of it, the position and those kinds of things. So again, from your perspective, it wouldn't be important for students to know the diagonals. Can you just say that again?
Okay, thank you. All right. So first of all, what I'd like to say is what we teach in PNF, we believe that if Maggie were still here, she would have evolved to where we are teaching now, because we knew her. We knew what, and when you look back at where the patterns developed in PNF, they were not what led the development of PNF. The patterns were something that evolved through observation, both manually and visually, of where and how they could apply their resistance to get the best global effect from their resistance or from their facilitation. So patterns were never the driving force. But now that you asked me about what do I think is important about the diagonals, I think it's important that we don't look at diagonals as being a pattern that has to be taught to someone so that they can do a PNF pattern. What we look at is a diagonal is simply a position for someone to assess through their hands the mechanical capacity of a patient's mobility, which can greatly influence functional tasks. You can't talk someone through improving their mechanical capacity. You need to know part of motor control is the ability to have dissociative options of movement. And if someone has limited mechanical capacity, they're not going to have that dissociation. So therefore, what's really important is that we have patterns that guide us in the ability to assess mechanical capacity within functional movements. And so the diagonals give us so much, but they are not the principle per se of PNF. The principle is teaching our students how to touch, how to be able to sense the neuromuscular response so that we know if our patients are responding with the core or responding with their phasic muscles. We understand their strategies, not by what we just see, by what we feel. And I think that that is something I'd rather see 2 hours spent on in an academic setting and then let the students pursue their interest where they find it, rather than trying to say that PNF is D1, D2.
Thank you very much. Does anybody else want to make a comment about their rationale for the curriculum as they teach it before we go on to the weather? My last question here, and maybe we've talked about this a little bit, but I'm again still interested in your perspective. What I had originally been thinking about is that can these approaches coexist in entry-level curricula? And I have heard some people say that they do, some people say that they do not, some people say they don't have time. And I'm wondering, maybe I'm going to rephrase that question is, do you feel like they confuse students? Do you feel like those approaches, so our contemporary approaches are drivers of neuroplasticity, task-specific training, intensity, those kinds of things. Do you feel like the framework or the background to that is too different or in opposition to the more traditional approaches so that they confuse students? And I think, Niam, did you have your hand up again?
Well, I do think they can coexist, but I happen to be in an extremely fortunate position in which I have 2 full semesters, 8 hours a week, in which to teach neuro rehab. So I am in a very unique position in that I have time. I have quite a lot of time in neuro rehab. When I teach it, I start both courses by looking at the principles of neuroplasticity. And then we explore all the ways in which we can tap into them. And I pull out PNF and what aspect of neuroplasticity principles does it tap into? The same with NDT, the same with task-specific training, CIMT, motor learning, all of those. And we do them all and we practice them all in the context of how they are changing movement and how they are facilitating activity-based therapy, because that's my focus, is activity-based. PNF has a lot of strategies for improving mobility and function. NDT is entirely based on changing and improving mobility and function. So I feel like once the students understand that their basic purpose is to achieve positive neuroplastic changes, they don't find the approaches incompatible. They find them very compatible, particularly as NDT has evolved to basically be a motor learning approach, because they have changed all of their foundation. They're based now on the systems, systems approach for motor learning, the dynamic systems model. They have given up their old thoughts. And when you look at the principles of NDT as it is taught now, it really is absolutely compatible with motor learning theory and motor control. PNF was based on neurophysiologic principles, 5 neurologic, Sherrington's neurophysiologic principles that are as valid today as they have ever been. And also the development of motor control. So I think they're compatible when they're not presented as separate approaches that are incompatible with each other. And I have not found students to be overly confused by them, because they're always looking at what can I do with this patient to achieve a positive neuroplastic change to improve their mobility and function. And so, but again, I'm in a unique position, I believe, in that I have 2 full courses in which to teach them at 8 hours a week each, to teach them a lot of options.
You know, I'm going to maybe, I'm getting a note that my internet connection is unstable. Okay, I'm going to direct this question to the whole group. So you know, I apologize that I'll say Ms. Tunney, because I heard the way that you pronounced your last name and not your first name. Say that, you know, so the whole focus is how can we change movement and function and drive neuroplasticity? I don't think anybody on this call would disagree with that, right? So is it important to name them? Like when I was just listening to what she was saying, she said, you know, NDT has evolved so that very consistent with motor learning principles. And so is it important, and I'm going to ask anybody to weigh in on that. Do you think one way that we could get at my question about this coexisting is to move away from the names? Catherine Mitchell. Hi, Kate.
Hi, good to see you. Yes, you know what, I think that's really what I've done. And I have really moved away from, I really have used more of it. I use definitely motor learning. I'm at Drexel, and we definitely have an evidence-based motor learning overlay to our curriculum. But the longer I teach, especially specifically with NDT, I mean, I have been teaching, I didn't answer the question correctly, but I'm going on my 19th year, and I do keep reevaluating curriculum, and I do it based on I'm also the assistant director of ClinEd, so I am watching what's being taught across the country, and I reevaluate. And if I'm teaching content that the students are never using, and I'm not seeing any new research on it. So for instance, you know, like Brunstrom, I pulled that out, you know, long before I reduced the naming of NDT. And that's really what I felt like if we could just really talk about the concepts of neuroplasticity and all the tools that we have, wouldn't it be better for us to be talking about that as opposed to giving it a name, especially with NDT, when I didn't have literature to support that. So that's really kind of, I've taken that approach too, Sue.
Thank you. Lynn English, what would you like to add?
I would like to add that I have a little bit different perspective from hearing from a friend who teaches NDT principles for 20 years across the country and giving me feedback about the students who come to her courses. I teach a very blended approach at the University of Kentucky. We do spend some labs in looking at movement analysis very deeply and adding how to facilitate using optimal theory, as well as making people aware of their movement strategies. We do mention Bobath because I think she was so instrumental in turning us toward, a positive direction in stroke rehab particularly. But what my friend who's taught thousands of therapists across the country says is that therapists come into their courses with seemingly very little understanding of the principles of movement analysis and being unable to target the lack of movement that's available. And I really took that to heart, and I want our students to leave us at the University of Kentucky with not only the motor control principles and current theory, but I want them to have some manual skills, not only in orthopedics, but in neurology, that will help them teach people to use what they may not be aware of. So I'm very much supportive of what Niam has been saying about blending those approaches and not losing what I think are very valuable aspects of those historical techniques.
So then, Lynn, you feel like it would, I hear what you're saying about the movement analysis and then placing your hands as one strategy to help teach people to move. I'm sure that there are probably a lot of different strategies, but the last sentence that you said, was it your perspective that you feel like it is important to name the strategies? Like, I know what you mean about, calling out Berta Bobath and these master clinicians that came before us, for sure. But are you saying you feel like it continues to be important to name the techniques, or to go more into the science and the strategy, if we consider movement analysis sort of a clinical science?
I think it's important to give credit to our historical mothers and fathers, and then to focus on the current science and make sure the students understand length tension relationships and biomechanics and external focus and all those things that are much more. So I'm not heavy on naming, but I do not want to discredit the people who brought us so far forward in their time.
Right. Thank you. Vicki Johnson, did you want to add something at this point?
I just want to thank
See your hand up, or was that from before?
Thank you. I just want to thank both Lynn and Niam, both of their comments, because it is disheartening to know that we are where we are today because we stand on the backs of giants. And I have always been one that I think the respect should be implanted within our students, that we didn't just suddenly become knowledgeable, that we have been built on people that have put themselves on the edge in so many ways to take our profession forward. And I think it's very easy to say they developed this approach, and here are some of the principles from that approach, and this person gave us this approach, and here's some of the principles, and we're going to look at how those principles or how those approaches blend in with the current science and the current model. But to no longer speak their name and honor them for what they gave our profession, I think is not the correct way to go.
I agree that we should honor those who have come before us, and that's probably true of a variety of areas of practice within physical therapy, for sure. Sorry. Oh my gosh. Carrie Fisher, you for sure have to say something.
Yeah, I didn't realize.
Carrie,
can you hear me?
Catalyst Fisher.
I didn't realize I was starting a revolution. It was an honest question. I graduated in 2002, so it was a while ago. And Terry Ellis was my professor, and I learned task-specific training and motor learning. And we, paid homage to the traditional approaches, and we learned a little bit, but it's not how I practiced for a long time. And as more and more evidence came out, it fit into what I learned. So that's where I went. And as I started teaching now, that the school that I'm currently at was teaching very differently, and I was confused. So I know when you ask whether students are confused, I was lost, and I didn't know what to tell them. I couldn't grade them. It was completely different. And I called some mentors because I I honestly didn't know what to do. So I was told to grade them on what they learned, whether or not it was something that how I practiced. But back to your other question, I do think the naming it is confusing. If you're telling me NDT has changed and it's now a motor learning approach, then what am I telling students? How? Well, no, it's the same thing as this, but this has a name on it. So I do think that's confusing. I also think we are teaching principles of neuroplasticity, and I guess, and I don't know enough about more traditional approaches. I definitely, but I guess I have a hard time because I don't know how, like Niam was saying, I don't know how they do fit into these principles. When the PNF instructor is there, I don't know how it fits into intensity, repetition, task specific, salience. So that's why I get a little confused, and I do have a hard time teaching it. So that's kind of why I blew up the world. It wasn't on purpose.
We're glad that you did. So for those of you who may not know, it was Carrie's original question on the listserv that birthed our conversation this evening. So we're glad that you did. Alicia O'Hara wanted to say something.
Hi. So I have a little bit different of a perspective. I've been in academia since September, so I'm really new to all of this. Prior to going into academia full time, I was a clinician for about 15 years in an urban neuro rehab setting. And like Carrie, I also went to Boston University and had a task-oriented approach to my own education, bought into it, and that's the way that I practiced. I'm in a unique position now where I was hired into a developing program where I can actually build the curriculum, where I don't necessarily have this responsibility to a curriculum that has already been established. And you asked the question, Dr. Perry, about whether or not contemporary and historical approaches can coexist. And where I'm struggling as I'm developing this curriculum is that if the research was equitable across these different approaches, then I think it would be easier for me to say, well, here are a bunch of tools for your toolbox. But because the literature isn't equitable, it's hard for me to justify including more historical approaches into the curriculum when at the same time our mission statement of the program talks about evidence-based practice. They have courses on evidence-based practice. We're weaving, and I understand that evidence has 3 legs to the stool, and it's not, and literature is just one of those legs. But it's hard for me to justify carving out time to these approaches when it's hard for me to gather evidence that supports them. And I feel like I'm contradicting myself by saying that, okay, we're going to include this too, but there's not a lot to support it.
Thank you. Although we probably do teach a lot of stuff for which there's not evidence, particularly in neuro, although it's getting better. That's my little side editorial. Brenda has her hand up.
I was just wondering if students have a certain amount of time to learn skills, how are they going to, if we don't name the 4 founders of this, how are they going to get better at whatever they do once they leave the school setting? Because they get very little practice in academia, and depending on where their clinicals are, they may not get a lot of practice in the neuro realm before they go out and get their first job. So I guess I don't know, if we don't name some of the 4 founders, how are they going to know where to get more education on the approaches that they have a little bit of knowledge about?
Would anyone like to answer that question? So I think the question on the table is, and again, I don't think anybody again on the call would say we shouldn't name the people, the giants on whose shoulders we stand. My question was sort of what, I can't remember who said it, maybe Alicia. if NDT has become a motor learning, you know, based on motor learning, is it important after we talk about the giants and giantesses, is it important to now say, all right, today's lab is about NDT? So I'm gonna call on Kate and Niam again, and then I'm gonna go to John because he's had his hand up for a while.
Okay.
So Kate,
Yes. So I would say that our students are pretty savvy at looking for, you know, continuing education. When we graduate, a lot of students, and they have the ability to be, if they want more information on a certain content, I think that they can evaluate the courses that are available, just like you would look for a new learning opportunity. Say, I want to look for something, you know, in the area of, you know, neurological rehab. And if it's marketed that way, they could then read that course description and look at that course and decide if that's how they want to spend their money. Because I think we could say the same with you know, musculoskeletal content. We can only teach so much of that. I mean, our curriculum uses a certain type of content that we don't teach the McKenzie approach, for instance, in orthopedic evaluation or treatment of the spine, but our students go to clinics where that's taught. And then they also may choose to take that expertise coursework later on, but that's something that they are going to then look into. I think that they have the ability to investigate and find a lot of other additional education. And I think, I'm not sure if it was Rachel said it earlier, but we do need to make sure that they are, continue to be lifelong learners. And that should be part of our responsibility because there is not enough time to teach them everything, for sure.
I would be remiss as the director of education to not say, oh, the Academy has plenty of wonderful educational offerings. But anyway, Niam, you wanted to say something in response to Brenda's comment as well,
No,
and then I'll call on John.
I just very briefly wanted to correct something that
No.
I said. I said NDT has incorporated motor learning into its education with handling as its with manual handling as its last resort. However, when they teach handling, they teach it in a very traditional NDT way, but they have incorporated the motor learning principles into their education. It's not the same as motor learning, but they have incorporated all those principles. So I just wanted to correct that in case there was a misconception. That's all.
Thank you. Thank you so much. John Hendrikus?
Yes. Good. Yeah, this is John Hendrakis from New York. So I'd like to, well, state my problem is getting, first of all, the majority of students of the class are not going for neuro. They're more musculoskeletal sports medicine. I'm trying to teach a basic understanding of how to be an entry-level therapist that's effective with patients and get them to understand the workings of the neurological system and how it affects neuroplasticity. What are the best techniques to affect change in your patients? So I think the traditional schools, and giving them people credit, as Niam and a number of other colleagues were saying, supports learning where we came from and how the nervous system works. As Vicky was saying, students want protocol. They want protocol. Spoon feed me, tell me what to do, and I'll just bang this out with my patient. I know it works. They would rather not understand it and do the critical thinking behind it. I want to teach them the critical thinking of why this would work and why this new evidence coming out, which they're going to see as they throughout their career, why this has a good chance of working, why you want to incorporate it, why I can take some pieces of NDT or Brunstrom or PNF and incorporate it into a newer task-oriented or motor learning or an intensity approach, why I think that would work. But the challenge is, how do I get, or how do we get entry-level students to understand the concepts of the neurological system, recovery from damage, neuroplasticity, what works best, in a limited amount of time. And I'm all for less is more. I don't have to teach you every technique, but if you know the groundwork and you know what this thing does, you can say, well, this could be part of this. So I do think it's important that they know what the contributors were by naming them, and yet to help them progress and learn principles, not protocols, and what works best on the nervous system when it receives, you know, this type of trauma, damage, disease, whatever, you know, whatever we encounter. Thanks.
Thank you. Yeah, and who knows, you know, in the next 10 years, we may all have less time as forces may reduce the length of our programs because of student debt. Who knows? Who knows?
And Sue, that's what I was thinking. Listen, if I had another semester, can we add another course?
No.
But that's more credits, that's more money. So, you know, we try to do the best with what we have, but I guess the key word is effectiveness, be efficient, give them what they need. Someone mentioned one of your poll questions, feedback from our affiliates, our clinicians. What are they seeing out there now? Staying current with not just your own local area, other areas. So that's why, you know, CSM is so important and our meetings are so important to get feedback of what are we seeing that works, and, you know, emphasize the effective principles. Thanks.
Yeah, and it also reminds me of we all have this constant challenge of what is need to know versus nice to know and what we can accomplish. And I think, again, that concept of in our whole programs, not just us neuroeducators, we need to instill that lifelong learning value so that learning goes on. So I think we're probably winding down our time together. I'm going to ask if anyone has anything else that they wanted to say. Vicki?
Thank you so much, and thank you again. The first thing I'd like to say is I would like to, it is very hard to explain, as Niam was saying earlier, when things evolve and change, it's hard to put that into words in a very short time. And I would like to invite any of you to be a guest at a continuing education course that I teach on PNF, just so you could understand the current way that PNF is being taught and how the perspective that we put those principles in, but more importantly, how we present PNF, not as a neurotechnique, but strictly as a motor learning technique and a technique to facilitate neuromuscular function for motor learning. I was so impressed a couple of years ago at CSM when there was a large research project presented out of Washington University saying, we're now applying motor learning to the orthopedic population. And it was really great to hear Dr. Hodges get up and talk about the importance of taking any situation and looking at the whole, the functional task, and then breaking that down into parts and then integrating it back into the whole. And that has always been the foundational principle of PNF. And I would love to look at how we can encourage our students to know that the principles and premises and philosophy of PNF should span their entire patient population, as well as be something that can enhance their neurological care. It will enhance their care across all patient populations and help them to hopefully facilitate efficient movement with all patients that walk in their door. So that's my, first of all, my summary and my invitation to all of you. If you ever want to attend a class, it's my gift to you, because I remember back in 1980, Greg and I did an educator symposium on PNF. We sent invitations to all the schools around the country and invited all the people who taught PNF to come to this class. And we spent a weekend just problem solving. And it was so much fun and so inspirational for all of us that were involved that weekend. And I would be honored to in any way contribute to your understanding of how PNF is now taught in the continuing education world, and see if that can in any way help you in making these decisions. So thank you very much.
Thank you very much. Christiana Collins. has her hand up.
Sorry about that. Thank you for calling me, and I'm sorry I had trouble getting in, so I was listening in. I am PNF trained, I am NDT trained, I've been a therapist for 30 years, and I do teach in neuro curriculum. And my concern with the idea of not teaching this content or not naming the content that we are teaching as PNF or NDT is that I think what our responsibility is to teach our students how to think, not to teach them PNF or NDT or any other technique, but to teach them how to think and to teach them to have an understanding of why they're doing what they're doing, why they are providing the input that they're providing to get that output. And whether it's through contemporary or traditional approaches, I think that those can, as has already been said, can be so well integrated. And my concern is that there are patients that I have a sister-in-law that's 55 and had a stroke, and had she not had the ability to have traditional intervention, she would have not moved for a long while. So I think we owe it to our students to give them as many tools as they can, not just in their hands, but in their thinking. And I think the principles that we have in PNF and NDT can very well be incorporated with contemporary approaches. And then the last thing, that is also really upsetting to me is I couldn't disagree more that we don't have enough evidence to support NDT and PNF, but I think we don't because those approaches don't really follow or bode well with the RCT model. And unfortunately, pragmatic research does not have the same level, is not considered the same level of evidence. But if you're looking at our vision as optimizing movement, and we're looking at individuals for what they are, individuals that come to us with a variety of different histories and backgrounds and all the different systems that affect movement, we can't put them in a protocol and do a PNF study or an NDT study that's protocol based. So I'd like to think that we need more, and we need more pragmatic studies, but the fact that we don't have the research to support it, I also don't believe that we have enough research to say that it doesn't work and we shouldn't be teaching it. So thank you for giving me an opportunity to speak.
Sure, but you know how you were just saying that it's about the principles and having teaching students how to think. Why does that mean that you would need to name these 2 hours or 3 hours of lab NDT? Because that's what you were responding to, the naming part of it.
Yeah, thank you for asking that. I think the naming is important only in the sense of understanding the reasoning behind it. I think the reasoning behind why NDT does what they do is different than the reasoning behind why PNF applies the inputs that they do. And I think understanding the rationale behind what we're doing is important. So an earlier concern was whether we're confusing our students or not. I think if we don't give them an opportunity to understand the reasoning behind why something works, and I think the naming of this is how Maggie Knott was thinking about this, and this is how Bobath was thinking about this, and this is how contemporary approaches work, it's easier actually to follow it. I think just giving them a variety of different ways of doing something and a variety of different ways of thinking makes it much harder. So I teach these approaches as a type of task-oriented approaches, where the parts that we're looking at are specific to the rationale and the reasoning behind the Bobath approach and the PNF approach. So I do think that it actually makes it easier if they do have a sense of where the rationale came from, than to just give them a variety of different things that are not necessarily grounded on, I don't want to say they're not grounded in theory, but not just a number of different ways of doing something. So I find it easier to actually provide them with the background of where things came from in terms of the thinking process.
Thank you. Thank you. All right, last call. It's got to be happy hour somewhere where some of you are. Any last comments? Brenda, is your hand, is that from before, or did you want to make another comment?
I only have more questions now that I've listened to everyone. I wrote in the chat that I have high hopes for the movement system diagnoses, because I do think students sometimes get lost about what they're treating. Are they treating instability? Are they treating too much stability? So I'm hoping as the movement system diagnoses evolves in the neurological population, that will help students know exactly what they're treating. And then, because I know NDT and a little bit about PNF, there are different strategies to address those different movement problems. So I think that's the complexity of neuro and why it's so hard to teach.
I agree. And, you know, just listening to you all and you know, talking about what we do explicitly always reminds me of how hard this topic is to teach, and how much we all really care about the clients that we have. And so we need to make that connection between all that. Well, I'm going to ask Andrea to make sure everybody can access chat, because if there are other things that the Academy can do to support neuroeducators, you know, since I've been the director of education, I have not done much for this group. My attentions have been elsewhere for the Academy, but I'm part of this group, so I'm self-serving in that. So if you have ideas of things that the board could adopt or strategies, would it make sense to have chats like this, resources on the web, etc. I would love to come away with a long list of ideas that you just type in into the chat, like Brenda said, that she mentioned about the movement system diagnoses. And I think one other person already wrote something there as well. I wish that I had some summary statement. I will say that the board is going to continue to think about this issue in terms of, as I said in the email introducing this, that these issues cross research, practice, and education, which came out in our conversation. And so should there be more funded research? Should we have a position paper on how to teach? Should we do more education for clinicians? Should we educate, you know, everybody go to Vicky's course and learn more about PNF? I don't know. But if you have ideas about that, I am all ears. Express my gratitude to all of you for your interest, particularly because what we do is so hard, and now we're doing it in the middle of a pandemic, which makes it harder. So everybody's lives are turned upside down. So again, I appreciate your passion and your willingness to hang with us this evening. So thank you. Judy Deutsch.
So I really enjoyed listening to the conversation, and I appreciate that the Academy hosted this as a beginning conversation. I'd like to say two things. One is, I don't think it's an issue that's US centric. I think it is a global conversation. So it could be amplified through, you know, the International Neurophysio Association, and several of our board members are attending this meeting at odd hours because they're in Austria and Australia. So we've been listening intently because we know that this resonates beyond the halls of this, you know, of our organization. So it's great that we started the conversation. So that's one. And then the other thing I thought as I was listening, and I am trained at a time when we had the named approaches. I did the 3-month Vallejo of Phil and PNF. I did NDT certification. So, and I trained in University of Southern California, where Rude taught. And a lot of the things she taught had to do with the relevance of the environment and how the environment shapes your responses to behavior. And her name is completely dropped off the list. But I recall moving from Southern California and interviewing on the East Coast, and somebody saying to me, Jeannie Levine, when I interviewed at Berk, saying to me, we do some brushing and we do some stroking. And I had no idea what she was talking about. I had no idea what she was talking about. I was like, what is that? I had never heard of brain stroke. And so I come from a perspective where there was a real lack of uniformity and there were regionalisms. and just listening to the conversation. I think that we have come a long way in terms of adopting fundamental principles that organize the way we think about managing neuro patients. So I think that that's encouraging. So I'd like to just offer that as the arc. And I think that what you hang on to and what you keep and how much you emphasize and you don't is a relevant conversation to have. And I think that if we can achieve uniformity, our students won't be confused, our patients won't be confused, our profession will move forward. So thank you very much for starting this conversation to the ANPT and really for allowing people to speak in a safe place. I think you've achieved that very nicely. So thank you.
Thank you. Oh, Anita Campbell has her hand up.
I'm not sure I have a lot more to say after what Judy said, so thank you for that. But all I wanted to add is all of this conversation really seems more about having a shared language. Whether you name an approach or not, it's about putting it in the context of the principles we understand, whether that be neuroplasticity, movement system diagnosis, motor control, motor learning principles. I think we need to go back to that shared language and having that, giving our students that as their foundation, that shared language, will help them regardless of the setting that they're in, right? If they understand that this technique is related to these principles, it allows them to take a technique, whether they've heard of it or not, and say that here's how it relates back to these foundational principles that we understand, that there is evidence for, and that we're continuing to look at. And so I think that if we're going to go anywhere, it's about creating, or really I think it's out there, that shared language and putting it out there so that all educators, all clinicians are using the same language. When you're talking about whether it be PNF, NDT, whatever approach that comes out next, it doesn't matter. If we relate it back to these foundational principles, we're all having the same conversation.
Thank you. Which goes along with what Judy said about uniformity at some point. So I am going to just say good night, good evening, good afternoon to everyone.